Good morning. We are actually back to Bangalore. We are preparing the new hall for classes. Today we'll have a seminar on thyroid disease, starting the anatomy and discussion on thyrotoxicosis. We'll have three presenters. One presenter is unable to present, so Milind will replace. So today the session will be moderated by Dr. Dhutiman Mitra, who is now an endocrine surgeon in Kolkata. He is associate professor of surgery at Calcutta Medical College. So Dhutiman and myself will moderate the session. We start with anatomy, and I hope the speaker will also speak some part on physiology of thyroid also. Okay, so we start with the first presentation.
Dr. Aditi, will you be able to share your screen?
আজকে আবার ক্লাস আছে।
হ্যালো,
সব মোবাইলে স্লাইড বানিয়ে সেখান থেকে শেয়ার করে, কিছু দেখা যায় না।
Yeah, Aditi.
hello. Good morning, respected sir.
Yeah.
Sir, my topic is surgical anatomy of thyroid. Thyroid is the largest endocrine gland situated anterior and lateral to the junction of larynx and trachea. Opposite.
Aditi, your audio is not very clear. Please come closer.
Hello.
Yeah.
Hello,
Better.
sir.
Yes.
Hello. Sir, is it okay?
Yeah, okay. Speak a bit loudly.
Yes, sir. Good morning, respected faculties. My topic is surgical anatomy of thyroid. Thyroid is the largest endocrine gland situated anterior and lateral to the junction of larynx and trachea opposite C5 to T1 vertebra. It weighs around 10 to 20 grams. Gland is made of right and left lobe, which is joined by the isthmus, and there is a pyramidal lobe present in some around 30% of individuals. Gland secretes T3 and T4 from follicular cells and calcitonin from parafollicular cells. Thyroid gland development. It arises as a midline diverticulum in the floor of pharynx. Cells are of endodermal origin. In week 3, there is a thickening in the floor of pharynx between first and second pharyngeal pouch, which invaginates ventrally into the mesoderm to form thyroid diverticulum. By week 5, there is formation of thyroglossal duct, which bifurcates at the tip and forms the thyroid lobes, lateral lobes, and the isthmus. By week 6, thyroid gland migrates to down in the neck in relation to trachea and larynx. By week 7, gland reaches its final position. Lower part of the thyroglossal duct makes the pyramidal lobe. Foramen cecum represents the vestigial remnant of the thyroglossal duct at the junction of second and at the junction of 2/3 of anterior and posterior 1/3 of the tongue. Surgical anatomy. Thyroid lobes. Thyroid lobes lies lateral to the trachea and esophagus and anteromedial to carotid sheath. and posteromedial to sternocleidomastoid, sternohyoid, sternothyroid, and omohyoid. Thyroid lobes has two borders, anterior thin and posterior rounded, more rounded border. And there are three surfaces: anterolateral, posterior, and medial surface. Medially, there is trachea and esophagus, recurrent laryngeal nerve, and inferior constrictor muscle of pharynx.
Aditi, come closer to the audio. You're sometimes heard well, but sometimes getting faded. Come
Hello.
closer to the audio. Yes, yes.
Yes, sir.
Yeah.
Laterally, there is anterolaterally there is sternocleidomastoid muscle, omohyoid, sternohyoid, and sternothyroid. Posteriorly, there is carotid sheath. The two lobes are joined in the midline by isthmus, whose superior edge lies at or just below the cricoid cartilage at the level of C7. Pyramidal lobe is present in 30% individuals only, and represents the distal end of the thyroid. Is surrounded by a thin layer of connective tissue, which is formed by the pretracheal layer of deep cervical fascia. It can be easily separated during surgery, and this layer coalesces posterolaterally to form the suspensory ligament of Berry. This is the point of fixation of thyroid to the surrounding structures. Thyroid extent. It extends above up to the oblique line of thyroid cartilage till the fourth to fifth tracheal ring below. And isthmus is at C7 level against the second to fourth tracheal ring. There are two capsules of thyroid, true and false capsule. True capsule is formed by the peripheral condensation of connective tissues of the gland, and false capsule is formed by pretracheal layer of deep cervical fascia. False capsule forms the suspensory ligament of Berry, which connects the lobe to the cricoid cartilage. Thyroid can get injured at this space during thyroidectomy. Thyroid is made of, functional unit is lobule, which is made of 24 to 40 follicles lined by cuboidal epithelial cells and supplied by one arteriole. By 3 months of intrauterine life, follicular cells starts to trap iodine, and thyroid hormone secretion begins. Iodine is trapped by the sodium iodine transporter, which is then oxidized to iodinium ion and then combined with the tyrosine residue of the thyroglobulin. This is then this forms the monoiodine and diiodine tyrosine residues, which then combines to form T3 and T4. This is stored in the colloid of the thyroid. When the signal comes from pituitary gland, TSH is released, and there is release of T3 and T4 in the blood. Arterial supply of thyroid. Thyroid is supplied by three arteries: superior thyroid artery, inferior thyroid artery, and thyroid emma artery. Superior thyroid artery is a branch of external carotid artery, and it lies in close proximity with external laryngeal nerve. Inferior thyroid artery is a branch of thyrocervical trunk, and it lies in close relation with recurrent laryngeal nerve. Thyroid emma artery is a branch of, it can be a branch of brachiocephalic artery or arch of aorta. Venous drainage is through superior thyroid vein and middle thyroid vein, inferior thyroid vein mainly. Superior and middle thyroid vein drains into internal jugular vein. Inferior thyroid vein drains into left brachiocephalic vein. There is fourth thyroid vein, also called vein of Kocher, which drains directly into the internal jugular vein. There is a dense capillary plexus present below the true capsule of the thyroid, which can get damaged during thyroidectomy. So to avoid hemorrhage during operation, thyroid is removed along with the true capsule of the thyroid. Thyroid has an extensive lymphatic network within and around it. Lymph from upper part of the thyroid lobe, thyroid glands, goes to the upper deep cervical lymph nodes, either directly or via laryngeal and through lower part of the gland, it goes to the lower deep cervical nodes, either directly or through pretracheal nodes or paratracheal lymph nodes. The subcapsular plexus drains into the Delphian nodes and the paratracheal nodes. Nerve supply of thyroid. Thyroid is supplied by recurrent laryngeal nerve, which is a branch of vagus nerve which runs posterior to the thyroid gland and enters the larynx at the cricothyroid joint. This is the point where it is at maximum risk of injury during surgery. To see this nerve, recurrent laryngeal nerve, thyroid is mobilized laterally where we can see it lying under the tubercle of Zucker candle. It can be located in the tracheoesophageal groove, where it forms the triangle of Beers. Beers triangle can be identified during the surgery to prevent the recurrent laryngeal nerve injury. On the right side, nerve recurs around the subclavian artery, and due to the less distance, it travels more obliquely to reach the tracheoesophageal groove. On the left side, it has arch. It recurs around the arch of aorta, and there is more distance so to reach the tracheoesophageal groove. So it runs parallel medially. Approx 2% of the recurrent laryngeal nerves on the right side are non-recurrent and enters the larynx from above directly. Vagus nerve arises from medulla, and at the base of skull, it passes through the jugular foramen and enters the carotid sheath, lying posterior to and in between internal jugular vein and internal carotid artery. From there, superior laryngeal nerve arises, and it descends towards the superior pole of thyroid, medial to the carotid sheath. There, at that level, it divides into two branches at the level of cornu of hyoid, approximately 2 to 3 centimeters above the superior pole of thyroid. It divides into the smaller internal branch and larger external branch. Internal laryngeal nerve penetrates directly to the thyroid membrane to give sensory innervation to the larynx above cranially to the vocal cord. External laryngeal nerve travels along the lateral surface of the thyroid lobule, thyroid gland, along the inferior pharyngeal constrictor muscle and descends anteriorly and medially along with the superior thyroid artery. And then it takes a medial course around within 1 centimeter of entering the superior thyroid artery to innervate the cricothyroid muscle. The right recurrent laryngeal nerve originates from the vagus as it crosses the right subclavian artery, and it then passes posterior to the subclavian artery and ascends to the trachea along the tracheoesophageal groove. Left recurrent laryngeal nerve originates anterior to arch of aorta, passes inferior and posterior medial to the aorta at the level of ligamentum arteriosum, and then ascends towards the larynx to enter the tracheoesophageal groove at the level of lower pole of thyroid. Here we can see the normal and the anomalous variations in the course of right recurrent laryngeal nerve. Image B is the normal course of normal course of recurrent laryngeal nerve. Image A is the non-recurrent laryngeal nerve in the setting of aberrant right subclavian artery. And there is image C, which shows the coexisting non-recurrent laryngeal nerve and the recurrent laryngeal nerve. There are thyroid gland anomalies like thyroid agenesis. There is failure of formation of thyroid gland. Lingual thyroid. Lingual thyroid is the failure of thyroid descent. Ectopic thyroid tissue. It may be found in anterior mediastinum or larynx or at the lower pole of normal thyroid. Thyroglossal duct remnants can be found, which as thyroglossal cyst or fistula. Thyroglossal cyst is the persistent part of thyroglossal duct, and it is the thyroglossal cyst is congenital, but thyroglossal fistula is not congenital. It represents the infection of thyroglossal cyst or inadequate removal of cyst during the operation. Thyroid imaging. We can do plain radiography, which shows paratracheal soft tissue mass, tracheal shift, calcification or bony destruction. On our USG ultrasound, normal parenchyma appears homogeneous. This is the normal thyroid ultrasound transverse section. Capsule is hypoechoic and represents hypoechoic line. Ultrasound can be used for diagnostic FNSE or biopsy, radiofrequency ablation, solid or cystic lesion, benign versus malignant lesion can be identified by ultrasound. Thyroid nodules can be identified. CT or MRI. Lymph node metastasis can be detected via CT, MRI, and extension of tumor or metastatic tissue metastasis into the adjacent tissues can be identified. Functional information of the gland can be assessed via 18 FDG PET scan. Metastatic thyroid cancer can be also identified. Thank you.
Okay, Dr. Aditi is a new first-year DME resident at Howrah District Hospital. You presented well. So, Dr. Ditiman, you can have some discussion for about 2-3 minutes for anatomy part.
Yes. Aditi, you have presented well, but certain information you must know when you are dealing with the thyroid anatomy. First of all, you said nerve supply to the thyroid. Actually, these are not nerve supply to the thyroid, but these are nerves which are in close relation to the thyroid. You have mentioned about the Beer's triangle, but there's one paper, The Rationale of Triangles in Relation to Thyroid Surgery, which was published in Indian Journal of Anatomy and Surgery, Head, Neck and Brain in 2018. You can go through that paper. There they have discussed in details many other triangles. Like Beer's triangle is also called Riedl's triangle. There's something called Simon's triangle, which is again for recurrent laryngeal nerve. Then there is Joel's triangle, the space of ribs for the external branch of the superior laryngeal nerve. So those things you have to know. You have to know the Cernia classification for external laryngeal branch. For all the residents, Cernia classification, all of you know almost about the external laryngeal nerve as to where it is crossing the superior thyroid artery. Apart from the Cernia classification, there is the Friedman classification and the Kierner classification. You said that the external laryngeal nerve traverses on the inferior constrictor and then enters into the cricothyroid. That is true, but there is variation of that. Depending on that, if it has a very long course on the external surface of the inferior constrictor going into the cricothyroid, then there is higher chance of damaging that nerve. So there are different 3 types according to the Friedman classification, which you should know. Then there are certain other terms like triangle of concern, unified area of danger. Everything has been discussed in that paper which I just mentioned. Please, you can go through that.
Yes, sir.
So these are important. But one important thing which you have not mentioned is the parathyroids. With relation to thyroid anatomy, you must describe the normal position of the parathyroids. Like the inferior parathyroids, they must be anterior to the recurrent laryngeal nerve. The superior parathyroids are behind the recurrent laryngeal nerves on both sides, giving a percentage sign. It is called a percentage sign. Superior is behind, inferior is in front and inferior. In 85% cases, this is the position, and one side mirrors the other side generally, as so far as the position of the parathyroids is concerned. Then What about supernumerary parathyroids, ectopic parathyroids? There is this Perrier classification for position of parathyroids, which you must know. There is classification from A to G, all those points you must know. And finally, one thing in imaging that you have mentioned, that 18F FDG PET, it's not very good for thyroid actually. In certain entities, which is called tennis, thyroglobulin elevated negative iodine scan for thyroid cancer. There only the role of FDG PET comes in. Otherwise, you use iodine scan or technetium participated iodine scans for thyroid imaging. If you have to do it, like in malignancy or when TSH is extremely low and you want to document a diffuse uptake to diagnose Graves. So these are the things I wanted to add. Otherwise, you have presented quite well.
Yeah, very well. Again, regarding the blood supply, you mentioned about the three major arteries.
Yes,
Apart from the three major arteries, there are a lot of small branches. Because once you ligate the small artery, you'll find during thyroidectomy, there are a lot of other vessels which are small vessels from the tracheal and esophageal branches. Okay, you should keep in mind that. Second thing is, if you are examining a patient of thyroid, when you start inspecting or palpating, you can palpate the anterior surface and the posterior surface of the gland. Medial surface of the lobe is not palpable. It is abutting on the trachea and esophagus. That is important because your anatomy knowledge you should apply on clinical part of your examination. Okay, so the other few important things. And second thing is, when you mention about the veins, one should emphasize that middle thyroid vein is very important. Why? It's a very small, slender vein we drain directly into the interjugular vein. That is the reason we tackle the middle thyroid vein early in the course of doing a thyroidectomy. Okay, and next thing is, if you talk of investigating thyroid disease, now there is a term like breast, we say triple assessment. In thyroid, we say quadruple assessment. Quadruple assessment is a thyroid function test followed by imaging and obviously a clinical examination. Okay, and next is a histological proof for any thyroid nodule. Okay, so that is the investigation part. And another investigation that is coming up and becomes standard of care now is genetic study. Once you have a thyroid nodule, you have done FNA, and sometimes FNA is not very corroborative. Now with this FNA sample, you can do a genetic study, and that can give us a lead that whether you're dealing with a malignancy or not. Okay, already you presented very well. Good, you keep on presenting subsequently also. So we pass on to the next presentation, etiology and clinical features of thyrotoxicosis.
Dr. Dhritiman. Hello, Dr. Dhritiman. Can you put it in the chat box, the paper you were talking of?
Yes, yes.
So Dr. Milind is a third year junior resident at MR Bangalore. Second year. So, chalo, Milind. Hello.
Good morning. Good morning, respected teachers and my fellow colleagues. I'm Dr. Milind Alokji, second year DNB PGT at Department of General Surgery, MR Bangalore Hospital. And I'll be talking today about thyrotoxicosis, etiology, and clinical features. Now, first of all, some definitions. What is thyrotoxicosis and what is hyperthyroidism? Thyrotoxicosis is a hypermetabolic clinical syndrome which occurs when there are elevated serum levels of T3 or T4 in the body. And an extremely severe form of this condition with hyperpyrexia and significant cardiovascular features is known as a thyroid storm. Hyperthyroidism, on the other hand, is when there is an increased production of thyroid hormones by the thyroid gland, which usually leads to thyrotoxicosis. Now, the causes can be of primary hyperthyroidism, thyrotoxicosis without hyperthyroidism, and secondary hyperthyroidism. Now, primary hyperthyroidism causes include Graves' disease, an activating mutation of the TSH receptor, which is usually autosomal dominant, a toxic multinodular goiter, toxic adenoma known as a Plummer's disease, functioning thyroid carcinoma metastasis, and drugs, in which case there is an iodine excess, a sudden iodine excess, that is the Jod based on phenomenon. Now, thyrotoxicosis without hyperthyroidism is seen in the case of struma ovariae, subacute thyroiditis in the initial stages. Initial stages of thyroid destruction, where there is radiation, infarction of the adenoma, and thyrotoxicosis factitia, where there is ingestion of excess thyroid hormone or thyroid tissue. And finally, secondary hyperthyroidism is seen in the case of TSH secreting pituitary adenoma, chorionic gonadotropin secreting tumors, and gestational thyrotoxicosis. Now, another way to look at the causes of hyperthyroidism is if we see that if we differentiate them based on increased hormone synthesis, in which case there will be an increased radioactive iodine uptake, or release of preformed hormones, where there is a decreased RAI. Now, here we see that Graves' disease. Now, here we see if we categorize it like this, then primary hyperthyroidism and secondary hyperthyroidism both come under category where there is an increased synthesis or increased hormone synthesis and increased RAIU. And then there are some causes such as struma ovariae and the others where there struma ovariae is a cause where there will be increased hormone synthesis, but in the other cases, there will be a release of preformed hormone, and these are thyrotoxicosis without hyperthyroidism. Now, briefly, since I've mentioned RAIU, I will just say a word about it. It is radioactive iodine uptake test, where radioisotope scanning is done using iodine 123. This assesses the size, shape, and distribution of activity in the thyroid gland. And there are various factors that affect the 24-hour radioiodine uptake, such as increased uptake in the case of hyperthyroidism, non-toxic goiter, Hashimoto thyroiditis, and decreased in the case of hypothyroidism, TSH resistance, and iodine excess. Now, the clinical features of thyrotoxicosis. Now, if we see that, basically thyroid, since we always, from physiology, we know that the thyroid hormone has an effect on nearly all the systems of the body, and therefore the clinical features can also be seen all over the body. Now, in the skin is usually moist, excessive sweating is there, and there's palmar erythema. Hair becomes fine and friable, and nails, there is onycholysis, as is plumber's nails. In the alimentary canal, there is increased appetite, weight loss. Cardiovascular system, tachycardia and the resting pulse is high. Atrial erythemas and fibrillations are common. In the nervous system, patient is restless. There is decreased attention span, emotional lability. Fine tremors is an important feature in the hands, tongues, eyelids. Musculoskeletal system, there is proximal muscle weakness, wasting, and periodic paralysis. Respiratory system, there is weakness of the respiratory muscles. Reproductive system, gynecomastia and irregular menstruation are important features, and overall there is heat intolerance. Now, eye signs are something that is very important in case of thyrotoxicosis, specifically seen in Graves' disease. Now, the evaluation of the eye signs is done with eye in the normal forward gaze. Now, some of the signs include lid lag, lid retraction, proptosis, periorbital edema, and peripheral field effects. This combination of lid lag, lid retraction, proptosis, and periorbital edema is together known as exophthalmos. Now, here we see this is what is lid, this is what the normal eye is like, and this is what is lid lag, and this is what is lid retraction. Now, this is again, this is lid lag and lid retraction. This is a picture of a lid lag with periorbital edema, and this is exophthalmos. So we come to the eye signs. Now, the eye signs, there are some signs that are due to adenergic overactivity, and there are some signs that are due to infiltrative ophthalmopathy. Due to adenergic overactivity, we have lid retraction that is higher than normal position of the upper eyelid. The Von Graf sign, which is the lag of the upper eyelid on the vertical movement of the eyeball. The Dalrymple sign, which is visibility of the upper sclera due to the upper eyelid retraction. And the Stelzach sign, which is a staring look. And due to infiltrative ophthalmopathy, we have the Mobius sign, that is inability to converge the eyeballs. The Navzinger sign, that is visualization of the protruded eyeball from behind the patient, and the Geoffroy's, which is absence of wriggling on the forehead or looking upwards. Now, Gray's ophthalmopathy has a grading. Now, this grading is the mnemonic, or the short form is the no specs, where from 0 to 6 we have the grading, 0 being no signs or symptoms, and 6 being complete eye loss. Proptosis, as here we seen, it has a fixed definition of more than 22 millimeters. Then we come to thyroid dermopathy. Now, the typical lesion is a non-inflamed indurated plaque with a deep pink or purple color or an orange skin appearance. The most common site is over the anterior and lateral aspects of the lower left, that is a pretibial myxedema. The skin changes can occur at other sites, and particularly they occur after trauma. Nodular involvement can occur and the condition can rarely extend over the whole lower leg and foot, mimicking elephantitis. So this is the nodular lesion, and these are classical lesion, and this is diffuse peritibial mixed edema, diffuse unilateral lesion. Now, briefly, I would like to mention about the Graves' disease and some of the things that are important here, because Graves' disease is one of the most important causes of thyrotoxicosis. It accounts for 60 to 80% cases of hyperthyroidism, and it occurs the peak age is 20 to 50 years of age. The cause is the thyroid stimulating antibody, the TSH-RAP, which is synthesized in the thyroid gland as well as in the bone marrow and the lymph node. Now, what causes TSI formation? The cause is not clearly known, but genetic factors such as the female gender, polymorphism in HLA-DR, CTLA4, PTPN22, and concordance is seen in monozygotic twins. Environmental factors such as stress, smoking, sudden increase in iodine intake, postpartum period are all hypothesized to be leading to TSI formation. Now here again, the majority of the clinical features, the basic clinical features are the same as in the case of thyrotoxicosis, but here we have to give specific emphasis to Graves' ophthalmopathy, as most of these have already been mentioned. The others including chemosis, keratitis, corneal ulceration, optic neuropathy are there. Now, locally in Graves' disease, thyroid enlargement is there, can be 2 to 3 times. There initially it is diffuse, firm consistency. There may be a palpable thrill, non-tender, and eventually nodular after several years. Retrosternal extension is rare. Audible bruit and venous hum might be there, but there is no nodal involvement. Thank you.
Very well presented, Milind.
Thank you.
I would like to point out certain things. Can you go back to the slides?
Yes.
And run us through so that I can remember what to say. Go back to the first slide. Quickly, most of the things have been properly covered. Is this okay? Achha, regarding thyroid storm, where you have mentioned thyroid storm, you must know the Barch-Wartowski scoring system, in which there is a prediction score as to which patients may develop thyroid storm. There, one criteria is temperature, and then there are cardiac features like tachycardia, presence of atrial fibrillation, and congestive cardiac failure. So that score is important because depending on that, there are certain recommendations according to the ATA for treatment. Next, you have mentioned hyperthyroid. Next, go back to the. Okay, now the current definition of Graves' disease is saying that if there is only one of the 3 features of AB, TSH receptor antibodies, or if there is orbitopathy, not only ophthalmopathy but orbitopathy, or if there is diffuse uptake in thyroid scan. Any one of the 3 features, if present, may be considered as a case of Graves' disease. Now, not only toxic adenoma, but also toxic MNG is called Plummer's disease. Okay. With respect to this, you have mentioned Jod-based phenomenon where iodine excess causes hyperthyroidism. That is, yes, that is in a patient who is iodine deficient. When you give iodine to that patient, but a patient who is already iodine rich, there if you give excess iodine, that will cause Wolff-Chaikoff effect, or that will rather cause thyroid constipation. And that is also called Plummerang. Like boomerang, it is called Plummerang because Plummer found this first, that if you treat a patient of Graves' disease with iodine in the preoperative period, then it causes less of thyroid storm or crisis. Next. This was okay. Go to the eye signs where you have mentioned the eye signs. Apart from the nose specs, the current, there are 2 things. One is the clinical activity score, which you must know, because depending on the clinical activity score and progress, you will decide whether what happens when you treat a patient of Graves' disease with radioactive iodine, the eye signs worsen. So if the clinical activity score of the eye signs is in such a range that it is graded as moderate to severe, there are recommendations in ATA that you should treat that patient with steroids before sending them for RAI, and several other recommendations are there. So you must know the clinical activity score, and the UGOGO classification, in which they have this is there only, but they have graded the amount of proptosis, they have graded the amount of lead retraction, then other factors like corneal involvement and all that, and optic nerve involvement. So UGOGO classification. So you must know clinical activity score, UGOGO classification, and the Bartovsky scoring for predicting which patients will develop thyroid storm. These three things are new in the ATA 2015. So these you should know. And where you have mentioned lead lag and lead retraction is something which you can see looking at the patient. Okay, yes. And lead lag is when you ask them to move the eyeball moves faster and the lead fails to follow the eyeball.
Vertical movement is slow.
That's by the one graphicide. Okay, these are some points. I mean, lead retraction and lead lag will not be the same thing. That is what I wanted to emphasize. And one Gifford sign is there, which I have not mentioned, but that is not done because that gives pain to the patient, where you fold the upper eyelid. Some examiners may ask you, what is Gifford sign? In exophthalmos due to endocrine causes, where it is due to autonomic nerve involvement, there you will not be able to evert the eyelid, but if it is a proptosis due to retroorbital tumor or something like that, then you can evert the eyelid. And there's something called the Cocker's eye sign. Actually, what happens is we mention the Stellwag sign and the Dalrymple sign. What is Dalrymple sign? It is
it's the lagging of the leads.
Lagging, lead retraction.
Lead retraction.
And what is Stellwag sign? It is infrequent blinking. Now, this infrequent blinking plus lead retraction, these two together give a staring look to the patient. Why does the patient appear to have a staring look? Because he's not blinking and because his eyelid is retracted. Now, combining these two, you may sometimes call this as the Cocker's eye sign. And regarding this Nafziger's method of assessing exophthalmos, it is a bit subjective. So, Hertel's exophthalmometer is an instrument with which you can exactly quantify the amount of proptosis. So this is asked. Sometimes you may be given picture of that in OSCE also in DNB exam. So that you have to know. And one test which is called the pen touch test has been devised. What happens is you touch the pen at your malar prominence, and then you move the pen to touch your eyebrow. In case of exophthalmos, you won't be able to keep the pen flat touching both the malar prominence and the eyebrow. This is a new test which is called the pen touch test. It is done in AIMS. So sometimes, if you have an examiner from North India, they might ask you these questions. Okay, this much I wanted to say.
Okay, and one thing is, Melinda correctly emphasized, what about primary and secondary hyperthyroidism? Yes. If you go to older surgical textbooks, you will find that primary hyperthyroidism is defined as swelling and hyperfunction at the same time, and nodule was there, and happened in later time is taken as secondary. Now the term has been changed. So keep in mind that primary hyperthyroidism is one where the gland is hypersecreting and leading to thyrotoxicosis. And secondary means there is, he already mentioned pituitary adenoma secreting TSH or other ectopic sites, SCDA secreting tumors. So these are the secondary hyperthyroidism. That is one thing you should keep in mind.
I want to add one thing, Milind. When you were saying about the investigations and all of Graves' disease, you must remember that since it is in a hyperproducing disease, so what happens is T3 is to T4 ratio is altered in patients with Graves' disease. That point you have to keep in mind. And always Graves' disease will be diffuse. That is also not true. There is an entity called nodular Graves' disease, which is also called Marin-Lenhart syndrome. Okay. Apart from the toxic MNG and all that.
Okay, so we pass on to the next presentation, management of thyrotoxicosis by Dr. Omkar Nath, who is second year PGT at MR Bangalore Hospital. Omkar, please start.
Good morning, sir, seniors, and my dear colleagues. I am Dr. Omkar Nath, second year DNB PGT from MR Bangalore Hospital, and I will be presenting investigation and management part of thyrotoxicosis. First, coming to the thyroid function test. In thyrotoxicosis, there will be increased serum T3 and T4 level, and TSH level will be either very low or undetectable. And if sometimes only T3 level is increased, and this is called as T3 toxicosis. Free T3 T4 estimation of
Sir, are the slides visible?
Slides are visible but not moving.
So I'll just share the screen. Sir, are they moving now?
Yes, yes.
Free T3 T4 estimation is done as total level will vary depending on the amount of thyroid binding globulin. Now, thyroid binding globulin is raised in various conditions like pregnancy, hyperestrogenism, and cirrhosis, while it decreases in condition with high androgen level, hypoproteinemia, and acromegaly. Now, coming to the types of disease, in conventional hyperthyroidism, there will be increased T4, T3, and T4, while TSH will be either low or undetectable. In T3 hyperthyroidism, T3 will be increased and TSH will be undetectable, while in subclinical hyperthyroidism, there will be undetectable TSH. And now coming to the radioactive iodine uptake, it is done by iodine 131 with a half-life of 8 days, and but it causes more radiation. And if we are doing technetium-99 scanning, it causes less radiation. It has a half-life of 6 hours, and scanning is done in 20 minutes after injection of technetium-99. So intravenous technetium-99 is used for diagnostic purpose. But there is drawback of technetium-99 scan, that it concentrates in the carcinoma, so from hot nodule. So hot nodule in technetium-99 scan is need not to be is benign. It is not benign. It is malignant. But on radioactive iodine scan, hot nodule will be benign. Autonomous toxic nodule is absolute indication for radioisotope scan in toxic thyroid showing hot nodule. Hypofunctioning cold nodule in grave disease could be malignant. So normally ultrasonography does not generally contribute to the differential diagnosis of thyrotoxicosis. We will see high radioactive iodine uptake in case of Graves' disease, toxic multinodular goiter, and toxic adenoma, while there will be low radioactive iodine uptake in case of subacute thyroiditis, postpartum thyroiditis, painless thyroiditis, and factitious thyroiditis. Other tests we will do thyroid releasing hormone estimation, ECG to look for cardiac involvement, and total count and neutrophil count before starting anti-thyroid drugs, because it can cause agranulocytosis. Now coming to the treatment parts, we have it is divided into three parts: and anti-thyroid drugs, surgery, and radioactive iodine therapy. First, coming to the anti-thyroid drugs, so indications. It is indicated in the pregnant woman if there is toxicity in pregnant woman, if there is toxicity in children and the young adult, and anti-thyroid drug is given before thyroidectomy to make the patient euthyroid, and also started soon after starting radioactive therapy. Now coming to the various anti-thyroid drugs. First, carbimazole. It is the most common drug used. Dose is 5 to 10 milligram 8 hourly. It suppresses the autoimmune process in thyroid in Graves' disease. Various side effects of carbimazole includes fever, rashes, liver cell dysfunction, myalgia, neuritis, psychosis. Now, methimazole. Methimazole is not used in the first trimester of pregnancy. Its dose is 20 to 40 milligram and but it causes cloacal and scalp abnormalities. Propylthyroidism. It acts by blocking thyroid hormone synthesis as well as by blocking peripheral conversion of T4 to T3. It decreases thyroid antibody levels. It is given for hyperthyroidism in children and in pregnancy and lactating mother. Dose is 200 milligram 4 to 8 hourly. It is short-acting and reserved for use in thyroid storm, first trimester of pregnancy, and methimazole allergy or intolerance. Now, beta-adrenergic blocking drugs like propranolol. Dose is 40 milligram TDS. It reduces the cardiac problems and also blocks the peripheral conversion of T4 and T3. It is contraindicated in bronchial asthma, heart block, and cardiac failure. It is very useful in toxicity induced due to thyroiditis, which is self-limiting. In case of thyroid storm, we give 2 milligram IV propranolol, and nedolol 160 mg can also be used in case of thyroid storm. Now, lugolcidine. It is the combination of 5% iodine and 10% potassium iodide. It decreases the vascularity of the gland and make it more firm and easier to handle during surgery. Dose of lugolcidine is 10 to 30 drops per day for 10 days prior to surgery. It prevents the release of hormone from the gland causing thyroid constipation. Dexamethasone. It inhibits peripheral conversion of T4 to T3. It is used in thyroid storm and dose is 2 milligram orally 6 hourly. Other drugs like potassium perchlorate, it inhibits iodide transport by direct inhibition of the sodium iodine transporter, used in amiodarone-induced type 1 thyrotoxicosis. Lithium carbonate, it inhibits coupling of iodotyrosines and prevent thyroid hormone release. It is useful when the thionamide is contraindicated. Other drugs like high dose of glucocorticoids is used in severe resistant or refractory cases. It impairs peripheral conversion of T4 and T3 and also lowers serum TSH level. Now, what are the advantages of anti-thyroid drug? It avoids surgery and its complication. It avoids radioiodine therapy and its problems. And clinical improvement will be seen in 2 weeks, within 2 weeks, and biochemical improvement occurs in 6 weeks after after anti-thyroid drugs therapy. What are the disadvantages? There is prolonged course of treatment, and in spite of this, we cannot predict the remission or relapse rate. Relapse rate is 40%, and the size of swelling may not regress as in case of toxic nodular goiter. It may lead to agranulocytosis and thrombocytopenia, liver damage, hair loss. Now, coming to the surgery, subtotal thyroidectomy is most commonly done, in which both lobes with isthmus are removed and tissue equivalent to 5 to 8 milligrams are left behind on both sides, both poles of the gland. But it is now observed that total thyroidectomy may be a better option in Graves' disease to achieve lowest relapse rate, as it clears the antigen focus in thyroid completely. In case of autonomous nodule, hemithyroidectomy is done. Now, what are the indications of surgery? If there is failure of drug treatment in primary thyrotoxicosis in young patient, in case of autonomous toxic nodular toxic goiter, if malignancy cannot be ruled out, Graves' disease in children, if there is the need of anti-thyroid drug for more than 2 years, in case of large goiter, sub-external or intrathoracic goiter, if there is presence of pressure symptoms, Graves' ophthalmopathy, and in case of amiodarone-induced thyrotoxicosis. Now, advantages of surgery. In surgery has a rapid and high cure rate. Problems of radioiodine therapy are avoided. Surgery provides tissue for biopsy and removes the occult malignant foci. And it is an option for women planning a child. Coexisting parathyroid carcinoma can be removed, and it is a better option for ophthalmopathy due to thyrotoxicosis. Now, disadvantages associated with surgery. It can there could be a recurrent thyrotoxicosis in 5% cases. There will be there's complication of thyroid surgery like hemorrhage, recurrent laryngeal nerve palsy, hypothyroidism, hypoparathyroidism, stitch granuloma, infection. In 20 to 45% cases, there will be thyroid insufficiency, which will revealed in 6 months to 2 years, 2 years, and confirmed by estimating T3, T4, and TSH level. Now, coming to the radioiodine therapy, it destroys the cells and causes a complete ablation of thyroid gland. It takes 3 months to get full response, and so until then, the patient has to take anti-thyroid drug. To give the therapeutic dose, patient has to be admitted and isolated for 7 days to prevent irradiation. It is given orally soon after getting from the manufacturer without much delay to have optimal efficacy. Now, what are the indications? In case of primary thyrotoxicosis, autonomous toxic nodule, and recurrent thyrotoxicosis. It is preferred for hyperthyroidism as it avoids surgery, but proper follow-up is needed. It causes fibrosis and destruction of the thyroid gland over weeks to many months, causing hypothyroidism. But effect is less rapid than drugs or thyroidectomy. Goal is to make the patient euthyroid, but it is avoided in children less than 5 years of age and pregnant women and lactating women. And there is the risk of hyperparathyroidism after radioiodine therapy. A contraindication. It is contraindicated in pregnancy, breastfeeding women, female desiring to have pregnancy within 1 year. It is not advisable in chronic smokers and not recommended for ophthalmopathy. Now, coming to the thyroid storm. In case of thyroid storm, there will be thyrotoxicosis that is elevated free T3, T4 level, and there will be at least one CNS manifestation plus one or more other symptoms like fever, tachycardia, cardiac heart failure, GI features, or a combination of at least 3 features among fever, gastrointestinal, CHF, or tachycardia. Now, coming to the management part, we will first initially we will give supportive treatment like IV fluid, oxygen therapy, and for fever, acetaminophen and cooling blanket is used. Patient should be admitted in ICU with closed cardiac monitoring and ventilatory support if needed. Precipitating factor like infection should be taken care of. And coming to the definitive management, to decrease adrenergic hyperactivity, beta blockers, and to prevent synthesis of hormone, propylthiouracil is used. Glucocorticoid inhibit hormone production and decrease peripheral conversion from T4 to T3. Lingual Thyroid is used due to high levels of the iodine. It will suppress release of thyroid hormones. Diuretics for cardiac failure and digoxin should be used for uncontrolled atrial fibrillation. Now, toxic thyroid in pregnancy. Among anti-thyroid drug, propylthiouracil is preferred. Subtotal or total thyroidectomy can be done in 2nd trimester, but radioactive iodine therapy is absolutely contraindicated. Toxic thyroid in children. Radioactive iodine therapy is absolutely contraindicated in children below 5 years, but recurrence rate is very high after surgery. So, proposed treatment is initially anti-thyroid drug given until adolescent period, and then subtotal thyroidectomy or radioactive iodine therapy after the age of 10 years. Now, for if there is patient of thyrotoxicosis with proptosis, early thyroidectomy is avoided because early surgery may precipitate malignant exophthalmos. So it should be treated initially with anti-thyroid drugs and if required with steroids until the proptosis remains static for 6 months. then subtotal thyroidectomy is done. Thank you.
You have presented well, but I would urge you to see, you know everything, but this has to be very streamlined so that you will be able to customize the treatment from patient to patient, different patients with different circumstances. So you should go through the American Thyroid Association guidelines. It was a special article by Douglas S. Ross et al. It is present in the 2016 American Thyroid Association guidelines, page 1343 to I'll look up and say 43 to 1398, followed by the references. There are 120.
So radioactive iodine treatment should come before surgery.
Yes. Now regarding radioactive iodine, you have said correctly that it should not be given to smokers, because in smokers there is worsening of eye signs more compared to normal population. So smoking has to be stopped before giving radioiodine. Now after radioiodine, you have to give anti-thyroid drugs from 3rd or 4th post-procedure day, because there may not be immediate control of hyperthyroid state. If at the 6th month after radioactive iodine therapy, the patient is still hyperthyroid or TSH is suppressed, you should go for 2nd radioiodine ablation. All these recommendations are given nicely. Then one more thing, say you are putting a patient on anti-thyroid drugs. Now, how long will you continue therapy? What is the end point of therapy? You can't be giving anti-thyroid drugs all through the life of the patient. You have also said failure of drug therapy. So when do you define it as a
What is the
failure?
optimal time for response and how long you continue?
12 to 18 months.
First response is 6 months.
6 months.
There should be optimal response about 6 months time, and usually most of the patient go to remission at the end of 1.5 to 2 years.
Yes. So even after that, if the patient has not gone into remission, you have to consider for surgery. The most, what do you mean by remission? You have to measure the TSH-RAB, that is anti-TSH antibodies or TSH receptor antibodies. You have to see whether they have normalized. That predicts that the patient has got cured, and also the TSH levels. Now, if it is not, you have to do surgery. The most important advantage of surgery is immediate control. Again, there are certain new recommendations that, these thyrotoxicosis patients, when you do a total thyroidectomy, mostly will do total thyroidectomy. They have a higher chance of developing hypocalcemia for reasons unknown. So, preloading of patients with calcium and vitamin D3, that is also a recommendation, calcitriol. So these recommendations have been nicely given. There are 124 recommendations with respect to treatment of hyperthyroidism. Go through the important ones. You do not have to remember everything. That will give you an idea when to start, when to stop, all those things. So like you have done thyroidectomy, when to stop beta blocker. There is no clear-cut recommendation, but 7 to 14 days generally we give. Okay, but anti-thyroid drugs are stopped right away from the next morning. When and how much should you start? L-troxin, how much and should you start and when for replacement? These are all given. 1.6 microgram per kg body weight.
You have done total thyroidectomy. You need not start immediately because the half-life is 7 to 13 days. So you can wait for 2 weeks.
You can start after some time. And how much dose will you start? 1.6 microgram per kg body weight. That is for the Western population. Indian population, they have done studies and they have found out the ratio to be 1.52 per microgram per kg body weight is good enough, they say. So there will be variations, but you go through those guidelines, that will give you an idea as to what is the best treatment for a particular patient. Pregnant patient, what will you do? Smoker, what will you do? Clinical activity score of the eyes, moderate to severe, what will you do? Okay. And then for orbitopathy, what you should do, that should be an important part of your
orbitopathy. There are a number of treatment.
Number of drugs have come up, like rituximab, tocilizumab. Rituximab is quite available in government setup also. Our patients before thyroidectomy, often thyroidectomy causes deterioration of eye signs also. So they are now giving rituximab to stabilize the eye signs and then sending the patient for surgery to us. So these treatment options, everything is given in that. You go through that guidelines by Ross et al. You just see Google Ross et al. Take your points from there. Okay. Otherwise, you have covered everything nicely presented.
And patient having irritation in the eye. A sunglass gives very good relief.
tears plus so methyl cellulose drops, etc.
yeah.
Those things are very good. Really gives
Any
really
comment from other faculty? Madam, you're there?
Yeah, I'm here.
Yeah.
No further comments. Just what I wanted
So,
from Dhriman
actually,
was.
we'll post in the group from next month. We will be having a new class coming up, because in last 1 year we have covered almost all the long cases and most of the short cases. So from next month we will be starting again fresh with hernias, and then pass on to the different long cases, and we will have seminars both on basic subjects and advanced systemic aspect. We will keep on 2 faculty lectures on recent advance in surgery, and we will have 1 journal club, and we will continue the OSCE. Because OSCE, I think, still will be there in the DNB exam. So I will request all the new PGT who are enrolled, please submit your name for your inclusion in the programs. Milind will post a message for this. Okay. So thank you, Dr. Didiman, for nice moderation. So you have a lot of things to go beyond the standard textbooks. So if you are preparing for the final exam, then some examiner might ask. It may not be an endocrine surgeon taking your exam, but some examiner having special interest on thyroid may have these stock questions coming up. So you must be knowing. So idea of having a seminar is to go into the depth of the particular subject. Okay. Thank you, madam. Thank you.
ম্যাডাম আমি দিয়েছি চ্যাট বক্সে আর্টিকেলটা, আপনি না পেলে আমি একটা তোমার হোয়াটসঅ্যাপ
আমি দেখতে পাচ্ছি না, আমি আমার চ্যাট বক্সটা খুললাম।
ওটা দেখুন ফর এভরিবডি। ওই
তুই আমায় হোয়াটসঅ্যাপ
put it in the group.
আমি আপনাকে হোয়াটসঅ্যাপ করে দিচ্ছি।
The group. Put in the group.
Thank you Makunda.
Thank you, sir. Thank you, students. Thank you, ma'am.
Thank you, sir.
Thank you, sir.